State of Cannabis.
This is the State of Cannabis News Digest, a roundup of this week's key developments in the cannabis industry.
Every Saturday at 9 a.m., we bring you the week's biggest cannabis policy developments from across the country. This broadcast uses AI-generated voices to help make the show more clear, varied, and dynamic. The reporting, writing, and editorial choices are guided by our news team. The voices help us present the program with more range, pace, and personality. Today on the program, federal cannabis rescheduling is starting to move from policy announcement to real-world regulation. The DEA is preparing new registration pathways for medical cannabis businesses. Oklahoma is already tying state compliance to federal registration, and veterans may get a clearer path to medical marijuana through VA doctors. Then we'll move through the states. Alabama is nearing its first legal medical cannabis sales. Georgia and Iowa are expanding patient access. California is considering drive-through cannabis sales. Indiana is preparing for a renewed medical marijuana debate. Louisiana is weighing both adult use policy and end-of-life patient access. New York is focused on consent in maternal and newborn drug testing. And Virginia is looking backward with a new law that could reopen sentences for older marijuana convictions. Stay with us for the details. And if you're new here, subscribe. If you're already subscribed, hit the like button.
And now here is the deeper look at the key events in the cannabis world this week.
We begin in Washington, where the Drug Enforcement Administration says it will soon expand its medical marijuana registration system beyond dispensaries. The DEA says updated forms are coming for medical marijuana manufacturers, bulk manufacturers, growers or cultivators, analytical labs, and distributors. Those forms will apply to businesses handling Schedule III medical marijuana and are expected to appear on the DEA diversion registration page in the coming weeks. The announcement follows the DEA's earlier launch of a registration form for medical marijuana dispensaries. That form gave retailers a pathway to register, but it left other parts of the state-licensed cannabis supply chain without a clear option during a 60-day expedited processing window scheduled to close June 26th. The registration system is tied to the Trump administration's marijuana rescheduling process. Last month, the Department of Justice announced that marijuana products regulated by state medical cannabis licenses, along with FDA-approved marijuana products, were being moved from Schedule I to Schedule III in phases. A broader administrative hearing on cannabis rescheduling is scheduled to begin June 29th. The DEA's existing dispensary form asks for detailed information about storage, ordering, dispensing, inventory, record-keeping, security, state licenses, suppliers, and personnel with access to controlled substances. It also asks whether a business handles recreational marijuana, even though only medical marijuana is currently being moved to Schedule III. The change could matter for cannabis businesses because Schedule III status may open the door to federal tax deductions that marijuana businesses are currently barred from taking under IRS Code 280E. The Treasury Department and IRS say they plan to issue guidance. For patients, the effect may not be immediate, but for growers, labs, manufacturers, distributors, and dispensaries, the coming forms could shape how state medical cannabis supply chains fit into the new federal framework.
Oklahoma is moving quickly to connect its medical cannabis industry to that new federal registration framework. The Oklahoma Bureau of Narcotics and Dangerous Drugs Control says medical cannabis manufacturers and distributors must register with the U.S. Drug Enforcement Administration. The agency issued the notice in a May 8th letter and bulletin to licensees. Under Oklahoma's notice, manufacturers and distributors that do not obtain DEA registration could face administrative sanctions, including possible revocation of their OBNDD registrations. The federal 60-day registration period began April 28, 2026. But Oklahoma says it will not consider enforcement actions until January 1st, 2027. Officials said the delay is meant to minimize the impact on businesses that are operating lawfully. For operators, the requirement adds a new federal layer to state compliance. DEA registration costs $794 and requires businesses to share certain information with federal law enforcement. There may also be financial effects. Registered firms would operate in full compliance with federal law and would no longer be subject to Internal Revenue Code Section 280E. That could mean immediate tax relief and access to traditional banking services. Observers had expected DEA registration could become a prerequisite for benefits such as 280E tax relief. Oklahoma is believed to be the first state agency to require DEA registration for medical cannabis operators to keep a state permit. That makes the state an early example of how cannabis businesses may be pulled into a more formal federal compliance system after rescheduling. For patients, the effect may not be immediate. The requirement is aimed at manufacturers and distributors, and enforcement is delayed until January 1st, 2027. But for the businesses supplying Oklahoma's medical marijuana market, the message is clear. Register with the DEA or risk state-level consequences next year.
Also at the federal level, the U.S. House of Representatives has voted to let military veterans get medical marijuana recommendations through doctors at the Department of Veterans Affairs. The amendment passed by voice vote on Thursday. It is sponsored by Representatives Brian Mast of Florida, Dave Joyce of Ohio, and Dina Titus of Nevada. The measure is now attached to the fiscal year 2027 Military Construction, Veterans Affairs, and Related Agencies Appropriations Act. Under current VA policy, doctors may talk with veterans about marijuana use, but they cannot recommend cannabis, make referrals, complete state forms, or register veterans for state-approved medical marijuana programs. That has meant veterans who want legal medical cannabis access often have to go outside the VA system, sometimes paying separate providers and keeping that certification outside their usual care network. The amendment would prevent the VA from using funds to enforce those restrictions in Veterans Health Directive 1315. It would not require a VA doctor to recommend cannabis, and it would not require the VA to supply marijuana. But in states with medical cannabis programs, it could allow VA doctors to help veterans pursue legal access when the doctor considers it appropriate. Supporters framed the amendment as a veterans' health care issue. Mast, a veteran who lost both legs and a finger in Afghanistan, said veterans should be able to discuss treatment options with the doctors they already see at the VA. Titus pointed to pain management, PTSD, and opioid addiction. Joyce said the issue is whether veterans should get advice from doctors or from bud tenders. The House also approved a separate amendment emphasizing VA research into psychedelic therapies and other areas such as traumatic brain injury care, oncology, and assistive devices. Similar veterans' medical cannabis measures have passed before, but were not enacted, so the House vote is a step forward, but the change is not final unless it survives the appropriations process and becomes law.
In Alabama, the state's medical cannabis program appears to be entering a new phase. Callie's Apothecary in Montgomery is expected to become Alabama's first operational medical cannabis dispensary, nearly 5 years after Governor Kay Ivey signed the Darren Wesley Ato Hall Compassion Act into law on May 17, 2021. The dispensary is days away from opening and has already ordered its first shipment of products. He expects between 200 and 300 patients from across Alabama once the store begins serving the public. The process will be tightly controlled. Patients will need to show identification, an official Alabama medical cannabis card, and proof of physician certification. They will be buzzed into the facility, then meet with an advisor or certified dispenser who can review the THC dosage recommended by their physician. The products will not include smokable flower. Alabama law prohibits raw cannabis plants, combustible products, and products that resemble candy or cookies. Cali's apothecary expects to offer state-permitted items such as gel cubes, tinctures, lozenges, pressed pills, and oils. Most patients are limited to 50 milligrams of medical cannabis per day unless they have special approval or a terminal illness. The program may serve patients with conditions such as post-traumatic stress disorder, chronic pain associated with diseases, depression, terminal illnesses, seizure disorders, and cancer. The opening could also mark a turning point for Alabama's cannabis industry. All medical cannabis sold in the state must be grown and processed inside Alabama. Cali's apothecary expects to add locations in Talladega and Bessemer by the end of the summer. For patients, the change is practical. After years of waiting, Alabama's first legal medical cannabis sales may finally be closed.
Georgia's medical cannabis program is getting a notable expansion. Governor Brian Kemp has signed SB 220, known as the Putting Georgia's Patients First Act. The bill passed the Senate 38-14 and the House 144-21 before reaching the governor's desk. The law changes the language in Georgia statutes from low THC oil to medical cannabis. That may sound like a small wording update, but it tracks with broader changes in the program. SB 220 adds lupus as a qualifying condition. It also revises how some existing qualifying conditions are defined and removes the requirement for many conditions that a patient's status be severe or end-stage before entering the medical cannabis program. The law also changes patient cards. Registry cards will now be valid for 5 years. Most patients still need annual certification from a physician, but patients with incurable or irreversible conditions do not. Patients and caregivers may choose electronic cards, physical cards, or both. Electronic cards may be used immediately for purchases once an eligible application is received. That could matter for patients who have been approved but are still waiting for paperwork. One of the biggest changes involves THC limits. Georgia is replacing its 5% THC cap with a 12,000 milligram THC possession limit for patients. The law also allows patients who are 21 or older to vape medical cannabis. Smoking is still prohibited for all patients, and people under 21 cannot smoke or vaporize medical cannabis. In his signing statement, Kemp said the changes are meaningful to affected patients, but do not materially alter Georgia's place in the national cannabis landscape. He also said the bill does not address recreational cannabis. For patients, the law may mean broader eligibility, more flexible cards, and another legal method of use for adults. For Georgia's medical cannabis businesses, it may mean a wider patient base and a different product framework, while the state remains firmly within a medical-only system.
Iowa's medical cannabis program may soon have more storefront access. Lawmakers have sent HF 990 to Governor Kim Reynolds. The bill would allow the state to license up to 10 medical cannabidiol dispensaries. Right now, Iowa law allows only 5. The bill passed with broad support. The House approved it 88-5, and the Senate approved it 42-5. It was sent to the governor on May 6, 2026. HF 990 would also adjust the state's registration card rules. The bill removes certain language requiring an Iowa residence address, and that change would allow out-of-state residents to register in the program if they receive certification from an Iowa healthcare provider. For patients, the dispensary change may be the most visible part of the bill. Supporters say Iowa's 5-location cap makes access difficult, especially in rural areas. Bridget Spittle of the Marijuana Policy Project said pharmacies are widely available across the state, but medical cannabis dispensaries remain capped at 5 locations for thousands of patients. The Iowa Medical Cannabidiol Board had already recommended more licenses in a 2023 report, saying additional locations could provide greater geographic access to medical cannabis products. Still, The bill would not turn Iowa into a broad cannabis market. The program remains medical. Flower and smoking are not allowed. Patients with certain qualifying conditions can generally obtain products containing no more than 4.5 grams of THC every 90 days. Healthcare practitioners may allow more for terminally ill patients or for patients already in the program when the provider believes the standard amount is not enough. For businesses, HF 990 may open the door to new dispensary applications. The bill changes the licensing process from a request for proposals process to an application process, and the state would license or relicense dispensaries by December 1st each year. The bill now sits with Governor Reynolds. She can sign it, veto it, or allow it to become law without her signature. If it becomes law, the effective date is July 1st, 2026.
In California, cannabis retailers may be one step closer to offering a service that many other businesses already use, the drive-through window. The State Assembly has passed AB 2697, a bill from Assemblymember Gail Pellerin that would allow licensed cannabis retailers and storefront micro-businesses to sell marijuana products to customers in vehicles. The vote was 55-9. The bill has now moved to the Senate, where it was read for the first time on May 12th and sent to the Rules Committee for assignment. The proposal would not create a statewide right for dispensaries to open drive-through lanes. Instead, cities and counties would decide whether to allow them. That means the bill is partly about cannabis access and partly about local control. Under AB 2697, sales would need to happen through a fixed-pane security window with a security drawer or a similar secure transfer system. The setup would have to be part of a building on the licensed premises. The bill would not apply to delivery-only businesses or cannabis licensees without storefronts open to the public. Supporters say the change could help medical cannabis patients, seniors, and people with mobility issues who may have trouble getting out of a car and walking into a dispensary. They also say the option could help licensed cannabis retailers compete with the illicit market. But the bill has drawn opposition from the California Narcotic Officers Association. The group says drive-through cannabis sales may raise risks tied to impaired driving, regulatory compliance, crime exposure, and traffic safety. It argues that selling cannabis through a vehicle window may create a closer connection between purchase and vehicle operation. For California's cannabis industry, the bill may become another test of how the state balances legal market access with local oversight and public safety concerns. The next stage is in the Senate.
Indiana may revisit medical marijuana in 2027. Republican State Senator Mike Bohacek says he is preparing legislation to legalize marijuana for medical use. The proposal would create rules for the use, sale, and distribution of medical marijuana. It would also set up a tax policy and update the state's impairment laws. Bohacek said the bill would include parameters to make sure medical marijuana is regulated and distributed by Hoosier healthcare professionals. He also said the proposal would not legalize recreational marijuana. The announcement comes after Governor Mike Braun said Indiana is more likely to address cannabis policy because of the federal government's recent marijuana reclassification. That federal change did not legalize marijuana across the country, but it did signal a different federal view of cannabis. Indiana has remained one of the few states without an effective medical or adult-use cannabis law. Braun has pointed out that Indiana is surrounded by states with either medical or recreational cannabis. Kentucky permits medical cannabis, while Illinois, Michigan, and Ohio allow recreational marijuana. Supporters see Bohacek's proposal as a possible opening. Jeff Staker, with Hoosier Veterans for Medical Cannabis, said it is a step in the right direction. He said Indiana should focus on doing it properly and suggested creating an Indiana Cannabis Commission with people from different sides of the issue. But the opposition is still clear. The Indiana Chamber of Commerce says it remains opposed to marijuana legalization in any form because of concerns about workplace safety and job performance. The Indiana Prosecuting Attorneys Council says it supports a total ban on THC products and warns that legalization could create public safety and regulatory problems. Bohacek's proposal also tries to answer some of those concerns. It would establish a blood concentration standard for THC impairment and create police training to identify impaired drivers. The bill has not yet been filed, and Republican legislative leaders have resisted marijuana legalization before. So for Indiana patients, cannabis businesses, and employers, the story is still at the proposal stage. But the 2027 session may bring a more direct debate over whether Indiana should create a medical marijuana program.
Louisiana lawmakers are considering a proposal that would create a state task force to study recreational marijuana legalization. House Concurrent Resolution 111, introduced by Representative Denise Marcel, would establish the Louisiana Recreational Cannabis Policy Task Force. The panel would study and make recommendations on whether Louisiana should legalize and regulate recreational marijuana. The resolution does not legalize adult-use cannabis. Instead, it sets up a review process. The task force would have to submit findings and recommendations to the legislature by February 1, 2027. The proposal says Louisiana already has a medical cannabis program, while other states have moved further by allowing adult-use sales. Those states have produced data on tax revenue, public health outcomes, criminal justice effects, and regulatory problems. HCR 111 says Louisiana, as a possible later adopting state, could study those models and try to avoid problems seen elsewhere, including market oversaturation, unstable revenue, and limited community reinvestment. The task force would study projected state and local tax revenue, licensing structures, taxation models, social equity policies, youth access, product safety, consumption limits, impaired driving, law enforcement impacts, and seed-to-sale tracking. It would also examine how recreational legalization could affect Louisiana's existing medical marijuana program. The measure was read by title and referred to the Committee on Administration of Criminal Justice on May 13, 2026. The proposal comes as Louisiana lawmakers consider several cannabis and drug policy measures. One separate bill would create an adult-use cannabis pilot program. Another would let patients with terminal and irreversible conditions use medical marijuana in hospitals. Other proposals involve penalties for smoking marijuana near school property and a psychedelic-assisted therapy pilot program. For now, HCR 111 is a study proposal, but it may help shape Louisiana's next major debate over cannabis policy.
Also in Louisiana, lawmakers have moved closer to allowing terminally ill patients to use medical marijuana during stays in certain healthcare facilities. SB 270, a bill sponsored by Senator Katrina Jackson Andrews, advanced after the House Health and Welfare Committee approved it in a unanimous 10-0 vote. The bill would enact a new law, RS 401046.5, to allow terminally ill patients in licensed healthcare facilities to use medical marijuana recommended under Louisiana's existing therapeutic marijuana law. If enacted, the bill record lists an effective date of August 1, 2026. The proposal would not allow smoking or vaping. It would also not require hospitals to provide marijuana, recommend it, or include it in discharge plans. Instead, hospitals and other covered facilities would need written policies for eligible patients. Patients or primary caregivers would be responsible for acquiring, administering, removing, and securely storing the cannabis. The product would have to be kept in a locked container provided by the patient. Healthcare professionals and staff would be prohibited from administering, storing, retrieving, or helping with the medical marijuana. The bill excludes behavioral health units, emergency departments, and outpatient hospital departments. It also includes language addressing the federal conflict over marijuana. Facilities could not bar a terminally ill patient's use solely because marijuana remains a Schedule I drug under federal law. But they could suspend compliance if federal agencies take action, or if federal rules expressly prohibit compliance. Supporters have described the proposal as a way to address a gap in end-of-life care. Louisiana legalized medical marijuana in 2015, but hospitals have generally barred patients from bringing cannabis products onto their premises. The bill now heads toward further House consideration. If approved there, it could return to the Senate for concurrence before going to Governor Jeff Landry.
In New York, lawmakers are weighing new limits on drug, cannabis, and alcohol testing of pregnant patients, postpartum patients, and newborns. Senate Bill S-845, sponsored by State Senator Julia Salazar, is titled the Maternal Health, Dignity, and Consent Act. The bill would amend the public health law and create new consent rules for testing and screening in pregnancy, postpartum care, and newborn care. The Senate Health Committee advanced the measure in an 11-2 vote, with one member absent. After that vote, the bill was reported and committed to the Senate Alcoholism and Substance Use Disorders Committee. The bill would generally prohibit healthcare professionals from performing a drug, cannabis, or alcohol test on a person who is pregnant or up to 1 year postpartum unless that person gives prior written and oral informed consent and the test is within the scope of medical care. Hospital-based screening would also require written and oral informed consent. Screening outside a hospital would require oral informed consent. For newborns, consent would need to come from the person authorized to consent for the newborn. Similar rules would apply, with written and oral consent for tests and hospital-based screens, and oral consent for screens outside hospitals. The bill also contains an emergency exception. Testing or screening without consent would be allowed when immediate medical attention is needed, and trying to obtain consent would delay treatment in a way that could increase risk to the patient's or newborn's life or health. Supporters say the proposal is meant to protect patient dignity and reduce unnecessary testing that can lead to family separation or other legal consequences. The bill would require consent materials to warn that positive results could have legal consequences, including a possible report to local child protective services. The proposal does not change cannabis sales or medical cannabis access in New York. It focuses on whether and how cannabis, drug, or alcohol testing happens in healthcare settings involving pregnant patients, postpartum patients, and newborns.
Finally, in Virginia, the state has enacted a marijuana resentencing law aimed at people still facing penalties for certain older cannabis offenses. Governor Abigail Spanberger signed HB 26 and SB 62 on May 14th. The bills are identical. HB 26 was sponsored by Delegate Rosia Hinson Jr., and SB 62 was sponsored by Senate President Pro Tem Louise Lucas. The law creates an automatic hearing process for certain people who were convicted of or adjudicated delinquent for felony marijuana-related offenses committed before July 1, 2021. That date is when Virginia's legalization of personal possession and home cultivation of marijuana took effect. To qualify, a person must still be incarcerated, on probation, or under community supervision on July 1, 2026. The covered offenses involve marijuana possession, manufacture, selling, giving, distribution, transportation, or delivery, along with certain related probation or supervision violations. The automatic feature is central to the law. State and local correctional facilities and supervision agencies must identify eligible people, notify them of their rights, and work with courts to schedule hearings. The original sentencing court must schedule hearings by January 1, 2027, or by April 1, 2027, if the marijuana offense was committed alongside another nonviolent offense. At the hearing, courts may reduce, vacate, or otherwise modify the sentence. They must consider that marijuana has been legalized, and they may reduce a sentence to time served unless the Commonwealth shows that relief would not be compatible with the public interest. The law was enacted after lawmakers rejected Governor Spanberger's proposed amendments. Those amendments would have required people to file petitions for relief and would have removed specific court deadlines. The legislature sent the original bill back, preserving automatic review. The law takes effect July 1, 2026, and sunsets July 1, 2029.
That's it for this week's Cannabis Policy Update. The big theme this week is movement without one single national rule. Federal rescheduling is beginning to reshape compliance. States are expanding medical access in different ways. Some lawmakers are studying adult use legalization, while others are focusing on patient rights, healthcare settings, or the consequences of older convictions. We'll be back next Saturday at 9 a.m. with the next round of cannabis policy developments from across the country. Until then, subscribe if you're new, hit like if you're already with us, and thanks for listening.